for his presentation.
Thank you very much. We are live, it seems, and good afternoon to everybody. Now, this is one of the many, web-based meetings that we are having these days, and I'm sure you people are all very busy attending them. Perhaps it is an overwhelming kind of a dose that is coming these days. And one has so much of choice that one can share or one can choose between which one to attend and which one not to attend. Anyway, today we are talking about some complex PCI cases. This is what we were told. And there are 4 participants in this meeting, as you all know, myself, Dr. Dhiman Kahali, PK Hazra, and Sreenivas Kumar. So I'll be presenting a complex PCI case, which we have done without the use of intravascular imaging. And Dr. Sreenivas Kumar later will also present some case in which intravascular imaging has been used. So going to the presentation, this patient I'm going to show is a 75-year-old female who is a non-diabetic, hypertensive for 10 years.
We are not seeing your slides, sir.
Can you see my slides?
No.
Oh, sorry. So I don't know what to do now. We have to ask somebody.
Actually, Dr.
Kahali has to stop sharing, then you will share.
Oh.
Dr. Kahali has to stop sharing.
One moment. Yep.
He wanted to show image guidance left main. Again, to avoid repeating, sir, I thought I would show some multivessel PCI cases.
I'm without image guidance.
Yeah, Dimal wanted to show, then I thought whatever is left out, I'll do it.
All right.
Yeah.
Can you now?
Yeah, now we can see your screen, sir. Go ahead.
Sorry for this glitch. Good afternoon, ladies and gentlemen. I'm going to present PCI case. 70.
করার চেষ্টা করছি আপনার ভিডিওটা অফ করে দিলাম কেউ আপনি দেখছেন না আমি দেখছি
10 years presented to us with angina on exertion for about 6 weeks, which was worsening for last 1 week. She was admitted on 13th of January this year. The examination was unacceptable except
Dr. Kahali's mic should be muted.
All right, can we proceed now? Hello?
Okay, sir. Go.
Yes, sir. It has been muted.
All right, thank you very much. Sinus bradycardia, left ventricular hypertrophy with strain. Were all normal. What do I do? Eyes are not moving.
Your button is there, no, sir. Take that and press that. Lower base. Okay.
Let's see.
Patient, it's not moving right now. Everything
It is moving, sir. We are seeing.
একটা কানের কর্ড হয়ে গেলে আপনার ইয়ে নেই না দাদা নিয়ে আসেননি না ইয়ারফোন শুভ অমরকে বল বাইরে কারোর একটা ইয়ারফোন জোগাড় করতে তাতে ও পারবে না
Is a very short left main and a very tight lesion in the proximal left anterior descending artery.
আপনার ভিডিওটা দেখতে হচ্ছে না অসুবিধা নেই করছি
Circumflex has a hazy looking centric synopsis. And as you can see, the LAO caudal is immediately diseased in a very, very short length, followed by a lesion in the circumflex. and circumflex proximally seems to be dilated. And then there is an abrupt change in the diameter here with a very mild disease after this dilated area is gone. So as you can see, this is almost a left dominant artery. The right artery is very, very small, although one can see a small posterior descending coming out of it. So basically it is a left main disease with a very short left main. The patient has 3 vessel left main coronary artery disease. We advise bypass surgery, but the patient was unwilling, and therefore she requested for percutaneous coronary intervention. The salient features of this patient are as follows. She's an elderly woman, somewhat frail looking with normal left ventricular function, a left dominant circulation, very short left main coronary artery with disease extending into the LAD and LCX. So this is Medina 1, 1, and 1. The LAD is smaller than LCX. And obviously here, if we have to do the PCI, we need 2 stent strategy for LMCA bifurcation. So as you know that there are many techniques by which 2 stents can be deployed in bifurcation lesions. What should be the optimal stenting technique? It should be a matter of discussion, which I think we'll do at the end of my presentation. But let me show you what we did and how did we do this case. The patient was preloaded with minoxidil, aspirin, and statin. We took a right femoral artery access, 7 French Judkins, 2 guide wires, both one in the LAD. Now this is the angiogram taken, and now you can see the pictures are much better. The previous one was the radial injection, and the right hand side LAO caudal shows you very clearly that this is a very short but critically diseased region. The LAD is also extending into the circumflex region, which is irregular and hazy in the proximal portion of the circumflex. Now, we first pre-dilated the LAD from the left main ostium to LAD with a 2.5 into 12 millimeters balloon. The balloon was, the proximal end of the balloon was kept outside the ostium of the left main coronary artery because it's a short lesion in total, so as we cover the entire length and prepare the bed. Then we went into the circumflex. The proximal circumflex lesion was dilated again with a 2.5 into 12 millimeters of 12 millimeter balloon, and also the ostium of the LCX and the left main was dilated with the same balloon. Now this is the result after the initial balloon dilatation. And
so why did you dilate the left main to LAD first? Why not fix the circumflex and come back to left main? Because if you produce dissection now, you have to stent the left main to LAD.
Yeah, the left main is
the circumflex.
Small length artery. And you know, most of the time we'll have to work with a guiding catheter outside the left main, and the lesion was very tight. Anyway, we had 2 wires in the left main. Okay. So basically we wanted to prepare the left main for entry of the stent. So this is the stent in the left main ostium to the circumflex. It is a 3.5 into 32 millimeter stent. The positioning is shown in the LAO caudal as well as in the RAO cranial views. And once we were satisfied with the position at the ostium of the left main, the stent was deployed at 16 atmospheric pressure. Then we pulled the same balloon back out into the ascending aorta and then re-inflated at 18 atmospheres to flare the ostium of the left main. And the result is shown on the right hand side. You can see the left main ostium, the circumflex are well dilated. The LAD is still flowing. And the next step obviously would be to put a wire through the stent into the LAD. As you can see, the LAD has been wired and now we have opened the strut. Initially we did it with 2.0 into 12 millimeters balloon at 16 atmosphere. Now this picture we have taken deliberately to show you a stent boost kind of a picture that we actually entered from the distal strut where the LAD lesion was there, and the proximal stent is somewhat deformed, and this part we will have to take care after we have deployed the stent in the LAD. So the LAD looks like about 2.75 millimeters in size. We used a 3.0 into 12 millimeter stent through the distal strut. And this is a 3.5 into 12 millimeters balloon, which is parked in the left circumflex artery. Now, having positioned this, this stent was deployed in the LAD with a tap technique, 16 atmospheres. Then the balloon pulled proximally, and a dilatation was done at 18 atmospheres pressure. This is the result after this, and the next step is to do a kissing balloon. So these two balloons, the 3.5 millimeter balloon in the LCX is now pulled back. The same balloon which was used for stenting, we have used it for a kissing balloon dilatation, and both balloons were inflated at 10 atmospheres each. So this gave us an approximate diameter in the left main artery of approximately 4.3 to 4.4 millimeters. Both balloons are then pulled back a little bit into the aorta, proximal to the osteum, and the final kissing balloon is here. This is the final result. As you can see, the result looks quite decent. Both arteries well flowing, the left main is well dilated, and the araeocranial also shows a satisfactory result. So this is what I wanted to show. Now there are some discussion points in this, and the main discussion point to my mind was that the proximal portion of the LCX was actually a little bit dilated. The actual size of the LCX, you can see, was smaller, maybe a little bit of dilated region in the proximal LCX. The LAD was smaller than the LCX. The angle subtended by the LAD on the left main was about 70 degrees or more than 70 degrees. So that's why we decided that we will do this by a tap technique. Although the length available in the LAD was somewhat small. So I would welcome comments or questions from my fellow colleagues, and then any questions from the participants, will be happy to take them.
I think if I'm allowed to make a commentary here, I will not criticize anything whatever you have done, because this is one way of fixing the left main. But if I'm given a chance to look back and redo the same case again, definitely I will go for radial, because that's my default strategy. Even 7 French 6 French can be done.
Okay.
Second point is fixing the circumflex, a short stent distally, fix it, optimize it. I will come back to the left main, image it. If I see the left main circumflex is all right, then I'll definitely go for a single stent from left main to LAD. Now, pre-dilatations from left main to LAD, once you pre-dilate, then you have dedicated tap. It's not a provisional tap anymore. There is no provision, because you have to stent the LAD because it is critical.
This is a dedicated tap, obviously.
Yes, you have mentioned, sir. You have mentioned that is a dedicated tap. Now, I will not pre-dilate first, because if you develop some kind of problem in the left end, you do not have any choice of fixing the circumflex distally, and you have to commit with one stent or two stent in the proximal part first. Then you can look back in the circumflex.
This was a pre-committed two stent, because this patient you cannot do with a provisional stent strategy at all. And okay, whether you do it from the radial or the femoral, I think is a matter of individual choice.
So that I agree, sir. There is not a point of a strong debate. And my observation, sir, you must have seen the circumflex maybe looking 3.5 and LAD looking 2.75. In practice, whatever looks, if circumflex looks 3.5, actually maybe 3. If LAD looks 2.75, it is actually 3 plus in proximal LAD. So this LAD sizing and circumflex sizing on angiogram sometimes can fool us. So if you go for some imaging, then maybe we can get a better dimensional choice. Nowadays the stents can be fixed. So if you have a tapering distal diameter, can be still fixed with 2.75.
I'm sorry, I cannot hear you properly.
Yes. Over to you, sir. Over to you, sir. I'm done.
We were not able to hear the last two sentences somehow.
Okay, sir. What I'm saying, on imaging, on angiogram, if you see a circumflex of 3.5 millimeter, actually on the IVUS, it may be around 3 millimeters. So you oversize on the angiogram and undersize the LAD So LAD here, I definitely estimate
I
it
would
to be
think
3
that
plus.
vice versa would be more true, though not necessarily always. If you're seeing
Yes,
a circumflex of 3.5, you won't see a 3 millimeter circumflex on the IVUS. And actually, this is a dilated circumflex. The actual size of the circumflex is smaller, as you saw the distal portion of the
It
artery.
is ectatic proximally. That's what sir means. Anyway,
Dilated artery have to match the
Omar.
size of the dilated artery with the stent. The two branches are definitely unequal in size, and therefore I could not think of any other strategy of putting two stents. You know, this is not a suitable case for a Q-large stent because of the unequal size. The angle is close to 80 degrees, so it's not a very good case for crush stenting also, because the length of the left vein is so small that even doing a tap technique with just 3 or 4 struts available to you, you know, it required a lot of thinking and planning.
one only thing, sir. Normally, all said and done, finally, patient is doing all right. It is fine. But in
So far-
general, you also agree that we try to always save and protect LAD because of the wide nature and the size matching here with LCX. I think you thought of putting it from left main to LCX. Agreed. But the lesion was most tight in the LAD. So I think sometimes when you're doing something here, if the LAD worsens and some suddenly patient could become a little unstable. That's why we tend to trilate the tightest lesion and treat it first. But you are forced to do this way probably because LCX size matched more bigger. You are thinking, I think. And
left main, that risk is always there. You know, the
Yeah.
left help was very, very tight,
Yeah.
and so was the LAD. But because of the size mismatch, you know, we had to do it with a tap.
Yes.
That you
But
have
generally speaking, in the whichever lesion is the tightest, and we tend to tackle that first and then go to the other vessel. And luckily, LAD flow didn't occlude because you pre-dilated it. But when you put a stent across, sometimes the flow could decrease suddenly and patient could become little unstable. That's why whichever is the tightest, you tend to tackle that first as a broad rule. But finally, each patient is different, and because of the nature of LCX being bigger, you have decided like that. I think that's fine.
that is also one of the reasons that we left a wire in the LAD.
Yeah, obviously we have to do it. Without wire, how will we do it, sir? Because tightest lesion.
Third wire with which we had crossed.
Yeah, another wire you recross the stent. That is perfect. I think we can have more discussion in the end with questions might come from chatting. I think we'll go on to the second presentation. Is Dr. Kahali ready for a presentation with image guided left main, which is requested?
Yes, Sreenivas, I was deaf and dumb for the last 20 minutes. Only I could see a part of the slides, courtesy Dr. Mr.
We are not able to hear you well, sir. I don't know what is the problem.
You could let me follow okay. I don't know what it's really. I was just deaf and dumb for the last 20 minutes. Let's go to the slides. Let me see whether it works or not.
Yeah, now in the end it became better.
So can you guys see?
Yeah, we can see him.
All was okay, you know.
Now it is okay, sir. Go to slide share and start
Line
presenting.
kete dijiye. Why are they doing like this? Line kete dijiye.
Yeah, no.
Now we are able to see your
So
screen.
am I audible?
Yes, go ahead. You can go to full screen. Press that below button. Yeah.
Sir,
That's
it's audible and visible both.
okay. Go ahead.
So can you listen to me? Can you listen to me, Sreenivas?
Yes. Go ahead, sir.
Sreenivas, can you listen to me?
We are. Go ahead.
So I'm going to. Can you listen to me?
Yes,
Yeah,
sir.
I am going to talk about one patient of mine with left main who came up to a STEMI, and we did tap technique. I don't think I have to tell about it because I have got such a august, faculty over here. Anyhow, we did this one, and this was a LMT bifurcation lesion, and the patient was a 57-year-old male patient. He was dyslipidemic, his cholesterol was very high, 280, thyroid function was normal, he was a non-smoker, non-diabetic, and he was admitted with acute anterior wall MI in another hospital, and he was thrombolized over there, I should tell, successfully, and he is a normotensive patient. And the echocardiogram performed over here didn't show any significant wall motion abnormality, and the LV ejection fraction was 60%. And the LV cavity showed, and the LV showed mild concentric hypertrophy, good RV systolic function, and on angiography there was left main bifurcation, and there was a patent stent in proximal LAD which was done somewhere else. And the patient refused CABG, and the surgeon also told me to go for. We had a heart team approach, the patient's relatives, and patient was also involved, and we had a consultation. And after heart team approach, we was advised by the surgeon to go for stent PTCA. Now you can see this is a Medina 00111 type of lesion. There is a very tight 99% left main distal, and the osteal LAD and osteal circumflex both has very significant lesion. And this is the subcostal view. So we have given a BMW wear in the circumflex and another wear in the LAD. And we decided that we should do circumflex as a main branch and this LAD as a side branch. And we did dilatation of the with a balloon, 3 millimeter balloon, and 3 into 12, I think, and we dilated the left main and the osteal circumflex. Next, we dilated the osteal LAD with the same balloon at 14 atmospheric pressure, and you can see the stent in the LAD, and there was no thrombus in the stent. So this is after the initial balloon dilatation. So this is a long DS, and you can see the lesion was very tight. As I told, that we decided to take circumflex as the main main vessel where it was going, and we put up the stent and deployed it at 15 atmospheric pressure for 38 seconds. So this is the picture. We have done a stent boost, and it showed good dilatation of the struts. So this is the picture after doing the left main to circumflex stenting. And we did some port also in the left main, and this is the picture you can see. And this is the stent we are giving in the proximal LAD overlapping the previous one. And then the final kissing balloon inflation was done. And this is the stent boost, where we can see that because IVUS was not available on that day. So this is the stent boost, and it showed beautiful dilatation. And it is the final picture. And the patient became completely free of chest pain, because even after thrombolysis, successful thrombolysis, the patient had agonizing chest pain. And was severely symptomatic with TROP-T positive. The cardiac enzymes highly elevated. The patient was little hypotensive and highly symptomatic. So these are the pictures. And I think we got a satisfactory result. However, we could not do the IVUS. And though it was an acute MI patient, normally we don't do also. But I would like to have one IVUS done. But as so technically, to conclude, technically left main bifurcation stenting is easy to perform with good results, and provided guidelines are followed. So this was an extremely critical patient with acute MI and a previous stent in the LAD, and the patient was having severe chest pain, and the patient was hemodynamically not very stable, but it was done nicely, and it is few years, and we did an angiogram after a year, and the stents were absolutely all right. I can't show it right now because of the COVID situation, and we are performing in the cath lab regularly and seeing patients because very few cath labs are performing, I think. And so the results were, I think, very good. So we can go for some discussion. And this is another patient with NSTEMI and transferred from another hospital with adequate medical treatment, including DAT and ECG, myocardial ischemia, ST segment depression, T-wave inversion. EF was 50% with anteroapical hypokinesia. And you can see that though the left main is not involved, both the LAD and the circumflex both are involved, and we went for a V-stenting in this patient, and the results were very good. This is initial balloon dilatation. Then we put 2 DES1 in LAD. It's not moving. So this is the dilatation of both the stents, V-stenting. The proximal area was free of disease. So the results were good. See the what is the final picture? So the results were good. Thank you. Sorry for the disruption of the video and the audio link. And if there are any questions, I'll try to have some discussion. We have very senior people like Dr. Shetty. Yes, Sreenivas, can you listen to me? I can't listen to you, Sreenivas. I can't listen.
Yeah, you can hear now.
Sir, we can hear you.
We have seen two of your cases of distal left bifurcation. Finally, the results are good. Patient is doing all right. That's what we wanted. But by and large, we tend to go more into LAD because LAD
normally we go into LAD,
but maybe because of sizes of LCX, because both cases it happened like that. I'm just highlighting that again. Sizes of LCX.
Small comment. Usually, when you have a left main bifurcation, the LAD is bigger than the circumflex. Usually.
Yes, I understand. That's what I'm saying, sir. Because if people should not think that we should commit to LCX always. That's why I mean.
The case that Divan has shown, the LAD was.
So LAD in this case, if you have noticed, sir, the LAD was not a type 4 LAD. It was a type 2 to 3 LAD, and circumflex was a larger vessel. You might have noticed that. So we took circumflex as the main vessel, and there was a stent in the side branch also, in the LAD also. So we decided to go. I made a comment that usually go from left main to LAD, but we went from LAD to from left main to circumflex therefore, because it was a large vessel.
LCX stent size was a little longer, I thought. Then what is it? Anyway, to cover that, you are probably, because of size problems, you must have taken. But generally, the more correctly we can place the stent is always better. There are some questions to you in the chat box. Can I read? Shall I go ahead and read it? Ramdev Yadav. Ramdev Yadav, why you left LCX at origin of OM1?
LCX, it was put to the LCX.
I think Karlekar was a part of left main. Was part of left main done? You didn't do part, but bifurcation is done. I think ideally, probably post after kissing.
Bifurcation.
It is better again to do final part. People recommend. That's what he was thinking. I think. Ramdev,
Yeah, we did a pot, I told you. It was edited, so the pot was not shown
Okay.
probably, but I mentioned that a pot was done after LCX only.
Okay.
So pot
Ramdev,
was
the other
done.
tap technique is inferior than culotte technique in BBC2 study. What are your comments?
Yeah, we know, but here it was convenient and the scenario was very critical. So, but some studies have shown that the results are good enough in TAP also. There are a few studies where they have shown that TAP the results are good. And I know there was a single study like DK Crush has proved that, DK Crush is a better technique, DK Crush 5 and the other DK, studies.
Dr. Sethi sir, would you like to comment on that?
The choice of doing a tap versus a culotte versus DK crush or a simultaneous kissing stent has to be made depending upon the individual patient anatomy. And I'll give you the example of my case as to why we chose a tap technique in this, although the choice was extremely difficult because of very short left main, hardly 3 millimeters or 4 millimeters long. One, when the size of the two arteries is unequal, then generally a simultaneous kissing in the left main or a culotte technique is not a preferred one, because in culotte technique you need more or less similar size of both vessels. Second, the angle of origin of the side branch, in which case, in this our case, we made LAD as a side branch. If it is more than 70 degrees, it is neither a good case for culotte nor a good case for crush. So you are left with a limited choice in that situation. So it is entirely dependent upon the type of bifurcation that you have, the size of the both branches and the angle of the carina that makes the decision as to what particular technique should be used in a given case.
Okay, sir. I think Ramdev Yadav was asking.
And also, Sreenivas, I want to put another point, because this patient was not an elective PCI. The patient had a STEMI and he was having severe post-MI angina. So the comfort of the operator is also important, because I believe TAP is a simpler technique than culotte. And so that is also an important factor. I think it's again done.
The most important is whatever we are comfortable, whatever you can do it perfectly, you have to do it. That is also important, because you want to do something which you are not comfortable, you will end in trouble. That other question, Dr. Sethi sir, he says, Ramdev Yadav says, sir, it is for you. There was another lesion at OM1, you left it untreated. You thought it is maybe not very tight or something.
No, actually, there was an abrupt
not very tight.
Of the circumflex. And if you notice that the circumflex in the proximal about 30 millimeters or so was actually dilated, which was larger than the actual diameter of this. So we thought that that lesion is not actually a true lesion. It actually looked a little worse after we put the stent. We hear about it, but mainly this.
It's not a significant lesion. It's not a significant lesion.
Let me just finish. Looking at the reference diameter in this case would be the non-dilated portion of the circumflex, and therefore we thought that that lesion was not significant. But we were forced to choose a larger stent in the circumflex because the proximal circumflex was dilated, and in any case the left vein is almost always more than 4 to 4.5 millimeters in diameter. So looking at both these things, we decided to put a larger stent in the circumflex and leave the other lesion because we thought that this was not significant.
That's a good point you made, sir. Basically, what Sethi sir was mentioning was, you don't compare it with the lesions with ectatic vessel. You compare with the so-called whichever you feel is a normal vessel, and then decide whether to do it or not. Many times, though it looks like a lesion, if you do FFR values, it could come negative in such sort of lesions. Because the problem is the proximal ectasia and not that lesion. I think we'll go to third lecture. Dr. Prakash Kumar Hazara, sir.
Thank you very much, Sreenivas. Thank you, sir, Professor Shetty.
We request
I can't anything, so please don't mind, I am departing.
You have to go, sir. You can, Dr. Hazara, sir, we are ready to hear to you.
Yeah, can you see my screen?
Yeah, I requested, sir, rather than again same coronary, requested he does some interesting micro cases. I requested him to show needless.
Can you see my screen?
Yeah, we are able to see you.
Okay, so Professor Sethi, Dimanda, Sreenivas, good afternoon. Sreenivas told me to show some
Dr. Hajra.
micro cases. It's not a very big thing. But this girl who was having complete heart block, congenital complete heart block, had 6 pacemakers from subclavians, then 2 epicardial, and repeated infections and repeated temporary pacemaker from the femoral. Both the femoral were critically, I would say, CTO. So the referring physician initially thought, who is a very talented person in GP Pod Hospital, he thought he'll open the vein and will put that micro pacemaker on the femoral side. I said, this micro is a big device. Even if you open the CTO of the vein, it is not like an artery. The large sheath will perforate, definitely perforate the femoral, iliac veins. It should not go for. So we abandoned the idea. Then we have gone for the jugular, and this is right internal jugular puncture. And it is not on ultrasound. It was basically above the clavicle. So if you puncture below the clavicle, and if you have any advertently done any damage to any major arteries, you can land up with huge trouble. This patient will never survive. So ideally should have been done on ultrasound guidance. Yeah, it was Sunday in GP Hospital, this ultrasound guy. I was surprised that in GP they are doing 25 cases on Sunday. And ultimately, it was like a normal procedure of internal jugular vein puncture. You confirm the tip of the wire or the sheath wire is in the IVC. So once you are in the IVC, that's for sure that you are in the venous system. You dilate with the normal dilator, then you can straight away, you have to work from the head end of the patient, or you can bend the whole thing. You can still work from the right side. So nothing great. After this, we have put one pigtail, and on the pigtail, you take an angiogram, and then you identify the septum, and you must pass the dilator with the ring in the IVC first. Then you remove the dilator and the wire and everything, keeping the ring in the mid portion of the area. And once you have done that, and once you push your micra, it automatically goes into the RV apex. So it was pushed to the RV apex. Then rest of the things are like routine things. You just release the micra, it stays there. And we got a threshold of 0.1. And on the 2 views, LAO and RA, we check it. So this girl from Jipmar, and this girl again, back sad story, after having a VSD repair, developed complete heart block. She was 9 years female, and she was admitted in Jipmar, that's a central institute like our PGI, AIMS or JVPAN, where the money is a constant. She got a special permission from the government for almost 12 lakhs micra. And this micra is not suitable for anybody whose body weight is less than 35 kg, and definitely not been recommended or done in 9 years female in the world. But since she had again 5 operations, and last time this temporary pacemaker, permanent pacemaker was hanging from right internal jugular vein. So we had a discussion and we said, let us do it from the iliac vein. Now, doing an iliac vein micra, it's a lot of effort you did. You call the surgeon, and the credit goes to a surgeon. Once they have given me the access of iliac vein, the rest of the things was done within 3 minutes. So instead of big credit, the credit goes to the surgeon. This guy, this guy had heart transplant in Portis Malar, Dr. Bala's case, and this guy came from US for heart transplant. And after 6 weeks, 6 weeks of immunotherapy, he developed 600 syndrome, 30-40 heart rate, and they tried many things. They kept on temporary pacemaker, screwing lead, and after this micra, he was all right. Now in transplant patient, it's a very interesting thing that you have 2 atria, like a recipient, a donor. Now we can put 2 leads in a recipient, a donor. It will work like the AI pacemaker, but both the leads are in the atria. which was very difficult because he had already ICD, CRT, so the subclavians were crowded. And patient wanted, because it is 6 sinus syndrome, patient wanted mica. Rest of the things are pretty simple. So this case, as I mentioned in Jipmer, was from the doctor, I forgot his name, anyway, thanks to him. So the surgeon gave me the access, and this was done. This is the guy who's got, I have done micro clip in Germany about 9 years ago. And that time I had an experience of having mitral clip at TAVR in 5 patients. Anyway, he is on LVAD and he was admitted to Dr. Kahali's institute once upon a time. Then he came to me. The LVAD was changed because of thrombosis in my hospital. Then he developed a 6 sinus syndrome A. The ICD got infected. Both subclavian crowded from left to right. So there was an access problem, and he developed this 6 sinus syndrome, and this is a micra. So he's carrying almost 1 crore rupees ornament in his heart. He's still surviving. And this is the micra on is a co-procedure or concomitant procedure from the same venous side with heparin, LA closer, and a micra. And this is another case. I think if you have a time, I will show you. Sreenivas, do you have a time for 2 minutes? Okay, so this is venous injections. Then from the femoral vein, you take this catheter, MP catheter. Then you go to the superior vena cava, exchange with the ampulazer, dilate the femoral, go on fluoro, see the ring there. Then you enter, make a swan neck, give a little push. And Sreenivas is also one of the expert of micra. He has loved doing micra in one of the very famous person in Andhra Pradesh, I think 3 months back, and our Chief Minister, Andhra Pradesh Chief Minister relation is doing well. So these procedures are very simple and very effective. Thresholds are pretty low, sometimes maybe less than 0.5 in 95% of cases. Attempt and reattempt. Maximum have done 5 recapture and ultimately got a good threshold. Recapturing, you have to align the micra with the cup. And if it works, fine. If it doesn't work, just pull it out and redeploy it. Pull heparin, 2 views, perpendicular to the septum. Septum is preferred because if you produce perforation, it is forgiving. But if you produce perforation and tamponade, there is only 1 case report of tamponade in the world. Then it's quite devastating. So wherever it goes, you take that as the best sweet spot of micra, push it, check it on angiogram, and deploy it. And usually in my follow-up, I lost 1 patient after 3 months. That was my second patient. Had status epilepticus, and nothing to do with the micra. Last month, I lost 1 patient in sepsis after having 3 months micra. It is retrievable. Now we are having double chamber or VDD micra, which soon be available, and it has been approved. So once you have finished your case, usually manual compression, figure of 8, or you can use ProGlide. In this case, we have developed, this patient developed some perforation fistula, and it had to be closed surgically. Over to you, and thank you for kind listening.
Can I ask a question from
Yes,
Dr.
sir.
Hello?
Yes, sir. Go ahead.
See, this is the patient with LVAD, looked very interesting. I could see some ICD lead in the right ventricle in that
Yes,
case.
sir.
And LVAD is known to produce quite complex device-device interactions.
Yes, sir.
When you put a device in a patient with LVAD, you know, whether it is a transvenous device or it is a subcutaneous device, when LVAD is actually introduced in the individual, the geometry of the left and the right ventricles and their relationship with each other changes completely.
Yes, sir.
Interventricular septum gets pulled to the left side because the left ventricle is unloaded by the left LVAD.
Absolutely right. You're spot on.
And you get a lot of electrical noises from the LVAD. So how did you sort of manage that, signals on the micra in terms of sensitivity settings, and what has been the follow of this case in terms of interference from the LVAD? Because that's a very serious concern in these people.
Okay, sir. So first of all, why he didn't micra in spite of having CRT or CRTD, all LVAD, they need some kind of defibrillations, because once they go into ventricular fibrillations, the RV stops. So either you have a BiVAD, both ventricular assist device, or if you have a LVAD, left-sided, you have to have a backup defibrillator, because most of the time, whose ejection fraction is very low, you need some kind of defibrillator because you have to protect the RV. So once you have an LVAD, usually it is basically magnetically elevated. I mean, it is basically soundless. It cannot produce any electrical interference, and is battery operated. So beauty of this micra with LVAD, it did not interfere with the LVAD rotor pump or the magnetic elevation pump. So battery is like quite outside, and in HeartMate 2, interaction is actually in the abdomen set.
The LVAD function is not affected. It is a pacemaker
no.
which is affected.
Okay. Hazraji, can you unshare, stop sharing your screen so that I will be ready?
Yeah. So basically, in LVAD, there is no electrical interference, no electromagnetic interference. And this ICD, there was a leakage. I mean, there was an insulation problem. So they said it is not pacing, but it can defibrillate. So we have to go for a pacemaker backup or 6 NS. That was the basic need for a micro pacemaker.
So anyway, I think if you have a malfunctioning lead of the ICD, I really wish you good luck, because this is you will eventually get into interference.
Listen, he had, I think this is the 4th ICD lead. He had a fracture, twice infections. So he said, you will not be able to put the transvenous lead. If the ICD malfunction, we have tested it, he is destined for subcutaneous ICD from Boston, sir.
Yes, even that is not very easy with the LVAD.
Yes, sir, I agree, but that is the only option, because both the subclavians are occluded now.
I think thanks for showing your excellent cases. I think we're running short of time. I just take this opportunity to thank Lupin for this webinar today. And I'm extremely happy to share the same platform as with Dr. K.K. Sethi, Dr. Hazra and Dimal Kahal, especially Dr. Sethi, because I don't know whether sir must have seen a lot of students, but Dr. Sethi, sir actually was my examiner. And when he came immediately to Lucknow, then since 2-3 years before, students were not passing it. You definitely will not have remembered, sir. But I remember, because a major thing for us in life. Then they were telling whether to pass first time or not. You said, I got a hypertrophic cardiomyopathy case, and Vanquish trial was just launched. You said this student did very well. He told about HOCM dynamic auscultation and Vanquish trial, which got published yesterday. Also, he answered, we should definitely pass him, you said. Anyway, thank you very much, sir. It's an honor to share the same platform with you. What I thought is, because I thought Dimal Kahal will be showing image-guided left main, which you said. So I chart whatever is left out, I will present. I thought I will take this opportunity to present something about multi-vessel PCI and what should be our approach, because we do see quite a commonly a lot of cases of multi-vessel PCI also in the country. Am I clear, audible?
Yes, you are.
Okay. Just 1 minute, sir. Slide is. This slide brings best wishes from Apollo Group of Hospitals. And this is my FACS Professional Services colleagues. I'm proud to present this because it's always a team effort. Whatever cases which are present, also all of them are involved. In hub and spoke model, we run services in multiple places. I think in tough times like COVID, this is a way to go. We help each other. This was appreciated by European Heart Journal too. And Apollo was also happy because it came in European Heart Journal. So this, with a brief intro, what I would like to mention is, though I've strictly spent more time on showing cases, but briefly I thought I would tell you what is the incidence of multi-vessel PCI and what is the decision-making process briefly and scientific basis for doing it compared to surgery. and then show in more, spend more time on the cases. And in the end, I would make some important announcement which we thought which is useful for most of the doctors which are viewing this webinar. As you see in this slide, initially we used to do PCI only for single vessel, and all the rest of the things were reserved for CABG. But with increasing technology and better quality stents available, now there's nothing like that which cannot be performed by PCI, provided you have a heart team approach and do right thing to the patient. If you see single vessel disease, predominantly 95% were taken by PTCA, and then multivessel disease in the 90s, it was surgery. But if you see in 2020, 80% of multivessel disease also is treated by PCI, and only a few percentage, 20% or so goes to surgery. Fortunate to collect our data of NIC, I thought I would show on the 2018, out of the 4,38,351 interventions which we did, about 25% of them were multivessel and 75% were single vessel disease. It's also thought that it's heartening to note that the decreasing incidence of restenosis in the country because of better quality stents, and though some percentages of bifurcation and all also mentioned, less prevalent for this. I'm also happy to share that rotablation usage and then imaging usage especially has gone up to 4.2%. About 154 centers were using imaging. That's a welcome change. It's very important for us to do it right when you're doing such complex cases. And multi-vessel PCI coming in decision-making process, though you say it as single vessel, double vessel, triple vessel, it's a question of semantics. What we need to understand is each vessel, where is the lesion, how critical is the lesion, and what is the LV function, what is the symptom status, all those help in a long way in decision-making process. When you have decided for multi-vessel, you have to do a complete revascularization, and probably you need not chase all the smaller vessels too. What is physiologically important we need to see, and that's how we take a decision. So what is revascularization? Defining complete means it's not that chase every vessel, but functionally complete, especially important to bigger vessels, we should do revascularization, and FFR goes a long way in telling us that. I would show some case examples for that. This is briefly, if you have a short focal lesions, we'll do it right. Multiple focal lesions and multiple these trials, which are trials, syntax, freedom, all showed that patients do well. No difference in mortalities, but we have to accept that slightly more increased TLR. Safety-wise, I think more safer towards PCI, and long-term events-wise, probably surgery scores are slightly better. So that is why, but though we have decided to do it, but it needs a lot of effort. We need to put in complete revascularization and do a proper job, especially when you're dealing with calcified vessels and unexpanded stents. This length of stent is no longer an issue. When we were students, it used to be told that the length of the stent will be equal to type of amount of percentage of restenosis. But now it is now this length more than 60 also is no problem with drug-eluting stents. And other problems are protecting, avoiding this pre-procedure MIs, which was an issue in the recent trials, and then calcification, such sort of things, and stent under expansion could be a problem. So even the surgery colleagues say that a lot of arterial conduits, op-cap usage, mid-cap, robotics are all used, but obviously you understand it's used in less than 1% of patients, so it's not available freely and it's not the answer for everything. We need to decide, and we also need to become wiser that stent thrombosis is much less, but similarly the graft occlusion rates have not significantly lessened. Still you see about 10% occlusions within the pre-discharge and about 45% occlusions are noted. Even lemas sometimes fail. So this is the flow chart I thought I'd briefly mention. A patient with 3-vessel disease, if you have no Euro score is okay and no procedural complexity of syntax score is high, for PCI probably this can go for surgery. But if syntax score is all right and the patient of heart team decides of PCI, then probably if it's a stable PCI, stable heart disease, the complex lesion, CTOs to be tackled first. If the outcome is okay, then he'll come back for the other revascularization in a staged way. If you can't open the important vessel at CTO again, he can go for surgery. But if the patient clinical scenario consideration is important, as you understand ACS or acute MI, we tackle the culprit vessel, and the complete other things also showed that staged PCI will be helpful. We were fortunate to do live transmission to TCT in 2012, and again 19, both happened to be also along with left main some multi-vessel disease. So this is we did a good image guided, OCT guided left main intervention. If you see this, such sort of very complicated case, we ourselves were thinking how we could tackle very thread-like left main. Fortunately, everything was okay. After this, this is not the point of discussion. That's why I just showed pre and post pictures here. And crossover stenting was done. And the OCT guidance gave us a good picture of LCX osteum, which was totally clear and it did not compromise at all. And later we did FFR. before adenosine and after adenosine, FFR was 0.88 and the patient did well, and we didn't do anything further. And that was all done in 45 minutes time thanks to technology. Coming back to topic today, multivessel PCI, another case which we did live demonstration. If you see here, LCX and RCA lesions are focused. LAD also has a mid-segment disease. He's a 69-year-old gentleman with unstable angina, had triple vessel disease. This picture is, I think, hope you are seeing the playing thing. This is LCX lesion, which is there here. And then LAD lesion, which we thought is more tighter. And then this other views showing the same. And LAD, I think there was no controversy. It was very tight lesion. That's how we thought we would finish the LAD lesion by stenting. We pre-dilated and put a stent. And then we got good result. Then we went on to show LCX. LCX lesion, which is here, which we thought some people were arguing the panel that it is important to stent it, but still we thought we would check. This is a new method of QFR calculation. Is directly you can calculate even when testing with a 5 French catheter too, but here we did it when live with a guide catheter. This is the way you analyze. You need to have two projections with at least 25 degrees angle separation, and then you calculate, and within 5 minutes you get a total calculation. And we got a QFR value of 0.85. QFR comes slightly 2 to 5, 0.2025 more than FFR. And then you can, beauty of it is if you have multiple lesions, you can scroll this bar here and calculate FFR like how we do it in now the latest versions of FFR. And then that's how we also showed the drift live again, and it exactly at that point of lesion, then it became less. That's why we thought we left LCX. Then RCA, we went on to show RCA. RCA again was a borderline lesion, but it looked a little more in this view and then more in right corner RAO views. And then we did a QFR. Value came as 0.80. This is online calculation which happened in 3 to 4 minutes without use of adenosine. Then we used adenosine surprisingly to show as a demonstration problems. In the live case also, a patient developed bradycardia and then we had to stabilize, and then later it came positive. Then we did stenting. This is not a great thing. Stenting was pre-dilated, stenting was done, and then result was quite good. And these patients are doing fine on follow-up now. That was the final result. Then coming back to some of the other scenarios which we face in day-to-day practice is a non-Nigerian 92-year-old male. Our patients are also simulating West now with history of CVA, hypertension, and then had recurrent rest angina. And obviously both surgeon and patient didn't want surgery, so we wanted to tackle it with the PCI. Also a major reason to select was he also had history of CVA. That's why we wanted, surgeon was very reluctant. See all the calcified vessels, diffuse nature of LCX and diffuse nature of LAD there. And then he understand, I think you're seeing there. So somehow RCA also had a lesion. We initially wanted, because the discussion happened, heart team, frailty, elderly person, TIA, CVAs, we wanted to avoid that. And then patient was taken up for PCI. I didn't go into all the steps, but basically pre-dilatation, then stenting done, and post-dilatation, again, both in LAD and LCX with good result. But patient developed some mild lacunar infarct. Again, we didn't do RCA stenting, and we kept it on follow-up. He's doing all right. Another case 3 is an interesting case of calcific disease, 81-year-old male, hypertensive diabetic, a CKD. Again, whenever you must have seen CKD maintenance hemodialysis, patients do develop a lot of calcific disease. And whenever he was on going for dialysis, he was getting diffuse inferior lateral STT depressions. And nephrology colleagues were also requesting to do something. And though recent CKD trial, ischemia CKD showed negative, but it doesn't apply for everything. We have to individualize this patient. See, the patient who's developing diffuse ST depressions are more threatened to infarct and get into trouble. So initially we took, and then tight lesion in the LCX eccentric, the 1.5 balloon somehow we could manage, and we did pre-dilatation. And then we were trying to take more bigger balloons, and then later the difficulty in negotiating balloons, we used a guide liner, and then still we couldn't pass the stent. Then that's a point where we exchanged totally with a rotawire, and then because it was not forgiving whatever balloon dilatation, so obviously we didn't try OPN balloon, but it wouldn't have gone easily. Then we took a rota and then did a rotablation to this LCX. And initially the pecking motions, you see, then finally it passed through. And then after the rotablation is done, then with the help of guide liner, we could place the stent. And obviously we need to get optimal result. We post-dilated with 3.5 NC balloons. Then we went on to right coronary artery, again a tortuous one. Initially also we tried to use 2 buddy wires, and try to do it. Again, as expected, it was challenging, it was not going. So we had to change, again, take the help of rota. As you see it here, rota ablation was done for the tightest lesion here. And then once the rota is done, then it was again bigger sized balloons we pre-dilated. And then nowadays, there's not a problem of conserving stents also because of cheaper price of stents, and it is difficult to navigate a long stent from here to here. That's why we decided to use separate stents, distal stent, mid stent, and the proximal stent. And the final result was good, and patient did all right, and he didn't have ischemia further on the dialysis. This is the last thing, another interesting case I wanted to show to highlight the importance of FFR. This is a 64-year-old male. A presentation was with non-STEMI, and he also had a LV dysfunction, acute LVF in the outside, recovered. Angio was done, and then he was referred here for probably surgery versus revascularization. If you see this angio carefully, and you have a very critical and subtotal occlusion of LCX, which is filling slowly. And then see this very faint filling, but it's also filling through collaterals. Then another thing was, if you see the LAD had two lesions. It had one here in at the point of septal, and the second lesion is in this point. So we were thinking whether if LAD is not very tight because it's diffuse long segment disease, then probably doing PCI could be okay, because LAD is normal. We don't want to, if not important, we don't want to send the patient for surgery. As expected, right side again had a critical disease, as we knew the angio before, but see the very critical narrowing with faint filling. And whether if you have observed the left side when it was dire, it was also giving collaterals to distal RCA. The plan was, again, we wanted to do FFR and see how important is the lesion of LAD. And if LAD was important, I thought I would again convince the patient for surgery. And that's how the thought process went. And this is the FFR wire which we put in LAD. And then FFR, as expected, came positive significantly. I will just show the value here. And we also tried to see the drift thing, how where it is. And the proximal LAD before adenosine 0.88, and post it became very significant. Patient started developing pain, discomfort 0.67. And then we did a stenting proximally, and we repeated FFR again to see the distal vessel, and it came 0.85 and 0.78. But somehow I was not very convinced. I would also show the pictures. And we thought a lot of collaterals it is being supplying to RCA, and we wanted to see what it comes after the RCA intervention is done, which is shown here. After the intervention to RCA is done, the same place FFR came negative. I'll take you through the steps. This is the same wire we used it to stent the proximal LAD. That is not the result was good. Then this is the appearance of distal lesion, those which were not looking very important. But then we thought we would still check again. Generally, people would say the critical lesion or total occlusion of LCX should have been tackled first before the LAD. I would agree. But having put a LAD wire there in the FFR to calculate FFR, and patient started becoming symptomatic, we immediately stented LAD to stabilize the patient. Then we nowadays use a Fielder XT type of wire. Generally, with some difficulty, we could negotiate it and crossed it. And then we dilated with the smaller balloons, bigger balloon, and then stented it. And the result of stent was quite good. There's nothing much to tell in it. But what I wanted to highlight was, see this, LCX, which was totally subtotal occlusion, became all right. And then we went on to see RCA, what it is, a very critical disease in the RCA. Then again, same Fielder XT wire. Most of the times, we'll be able to, very faint channels, we'll be able to get out usage with the Fielder XT type of wires, dilated with a smaller balloon. Then that is the stent which is placed. Then we had to, had another lesion, we had to put another. Then after opening, we thought there is another significant lesion below. Then probably another stent was put. Final result was good. So then after doing the RCA, because collateral coming from the LAD was left, decreased, now we wanted to check whether LAD will still come positive. As expected, this is a important message which I want to tell everybody, that if area of supply becomes less and the perfusion is less, probably even if the lesions which are look little tighter, especially the branchial vessels, the lesions could come negative. And that's how we did not, this is again FFR calculations after the RCA. Now you don't see much of collaterals coming here. And that's how this is a most significant positive baseline value. For sake of time, I didn't have put all the FFR pictures, but the values I have mentioned. So in other words, to say this clearly highlights the importance of FFR in assessment in multivessel PCI, and do what is best for these patients. But when you do it, we need to plan a complete revascularization, proper stent expansion, minimize myocardial injury, and it needs a lot of hard work. And why we all tend to do all this is what we feel. Our patients will be enjoying the next day in beaches, unlike the surgery patient who will be stuck in ICUs with a lot of drips and all that. That is a great thing which we love to see our patients being happy. And now here to say that PCI will increase further, CABG will decrease, and only very complicated, more worse disease could go to surgeons. But unfortunately, surgeons are becoming less experienced. Probably hybrid revascularization like Lima to LED and DES to RCA and LCX, probably if the cost is not an issue, could be the most optimal, ideal for our patients in future. And we need to work together to develop these protocols. If you ask for patients, most of them would prefer a less invasive PCI, but we need to have a heart team approach and try to do what is best for the patients. And probably as of today, any PCI syntax score of less than 32, we can safely do procedures without much of problem. Very highly complicated cases with total occlusions, especially you have more than 2 total occlusions. Those are subsets of patients which could go for surgery even today. And image guidance and taking help of FFR, QFR values like what is shown helps us to do what is right to the patients. And before I conclude, I would like to share this news that Apollo was in news recently. We did 5 towers on a single day. And obviously, why I wanted to project this is basically many doctors who are participating in these webinars. I would like to mention that there are very few hospitals which have completed half centuries in doing towers. This all happened, fortunately, thanks to Dr. Sushil Kodali support from Columbia University in New York. And most of the patients did well. Only one non-procedural dilated death we had on day 5. 2 patients required pacemakers. That is a news for that is a happy thing. Another important entity we are conquering for the sick patients. Thank you for patient hearing. I think we can go for discussion.
Right. Sreenivas, can you name one trial of left main where randomization was done based on syntax score?
All trials are randomization and done based on syntax score. All trials.
No. Tell me which trial was randomized. Which trial was done where the randomization was done based on syntax score?
No, the syntax score was calculated in all the trials. You mean to say that is not the primary entry point? You're saying?
Yes.
Can you make the screen bigger so that Sethi sir was telling we can all see each other better?
Yeah. So the first trial, syntax trial, these recommendations low, mid, intermediate, or high.
Yeah, now we are able to see.
Group analysis of the subsets.
I'll take 3 minutes to explain you that. Yeah. Basically, syntax. You would like to take that, sir? Sethi sir, or shall I tell?
Carry on.
Okay. Basically syntax trial is the one where the syntax score started basically. And it is again to tell you not only the physiological importance but anatomical complexities were all taken into the syntax basically. Later on, modification of it came with the functional importance also, that is the patient comorbidity and functional importance. It is later called as syntax 2. But any multivessel PCI, which included left mains also in this, had calculations of syntax score. That's why we became wiser to say that anybody who has more than 33 will do better with surgery. Anybody who has less than 18, actually, its PCI was better than surgery.
No, I'm not asking that, Sreenivas. Everybody knows
okay.
That. What I'm asking is a simple question. Can you name one trial? Freedom was like 30, one left main trial where the randomization was done based on syntax score, 21, 22, 33, 1 bracket, 25, 1 bracket, 31 bracket. The syntax trial was not randomized based on syntax score.
No, left main, how can you just randomize only on a syntax? Left main is one disease. You can't use syntax for randomization in left main. You have to understand what you're saying. Okay. But all the Excel trial, which was done again, the latest is Excel trial, Noble trial, syntax score was calculated in them. And then because initially more than 33 syntax score surgery was good, what was thought in Excel trial is to take only patients who are less than 33, only lower and mid-tertial at the site level. But when it was sent to core lab, again 25% of them had a higher syntax score even in Excel, but still patients did okay.
That is inclusive criteria, Sreenivas. This is not randomization based on, as you have rightly mentioned, left main cannot be randomized based on syntax.
Now, obviously, in left main only one lesion, how will you use syntax score for randomization? What I thought is whether you are tested left main, even a high syntax score, that is also done, I am saying. Okay. But you can't randomize the left main only with syntax. Syntax is for multivessel plus left main, no? Isolated left main, you cannot randomize only by syntax. But now we have long-term data. Now recently Greg Stone presented a long-term 5 years follow-up of Excel. Lot of criticism with Taggart and other surgical colleagues came that data was fudged and all that. He came with very beautiful explanations and more significant analysis. I think Dr. Sethi and others would have read it. But what I would like to say of benefit of listeners, I would like to mention it. Basically, he has every criticism was TLR. As we understand, he's a clever man. He removed TLR and also added myocardial infarctions in the analysis. Fair enough. But what his point of view is, TLR is not an important in today's era. If patient needs another stent, we'll put one more stent. But patient dying with MI is more important. That's why it's included. He was wanting to support it. But anyway, when criticism came, he analyzed the TLR also in the latest 5-year analysis now. And then TLRs were also slightly more, but not very important. But what is most important, which came out in the recent analysis, was when we were trying to see the mortality patterns and the event rates. In the early part, actually, patients did worse with surgery, and the long term, patients did bad with PCI because of repeat procedures. But pehle to patient has to survive and go home comfortably to have a better events on follow-up. And then he subjected the two important analysis like patient requested analysis and doctor physician analysis. This is another important concept I didn't know before. He has analyzed specifically in this 5 years plus syntax of Excel and said that what is the patient preference, what is the physician's preference. Obviously, everybody said initially we have to survive to have a better event rates. How much ever increased problems you would accept in the long term, they said. Patients specific analysis, patients were told, I believe, even if they're willing to die twice more than surgery, still they would accept PCIs only. That's various types of difficult analysis is put in. But even the long
and also, Dr. Sreenivas, there is a point in favor of PCI that the incidence of stroke was much more. In all the trials, it was from 6 to 17 times higher in the different. There was a meta-analysis done, and that showed it was 0.1% the incidence of stroke with PCI, and it was 1.7% with CABG. So in other trials also, so it's from 7 to 17 times higher the incidence of stroke, and people want to go on with a stroke with one side paralyzed, rather than to have a nice life. So I totally agree with you. And the Excel trial categorically showed another thing. The TVR was almost same in the this group against the CABG group, PCI and CABG group. There's not much of a difference, which was statistically not significant. And the mortality was also same, and PCI was shown to be non-inferior to CABG in all the aspects.
Yeah, Dr. Sethi wants to tell anything? Otherwise, we'll go on to some questions from the chat. Is it okay, sir?
Yeah.
Okay. Then
fine. Your lecture was very good, Sreenivas.
No, thank you, sir. I thought
why I didn't do IVAS apart from the thing, in acute MI, normally people don't go for IVAS.
But I thought,
in France also, Mark Silvestri, Joe Fajade, they go for 7 to 10% of the patients, they go for IVAS, even in left main stent.
I understand, but I thought for sake of discussion.
But okay, when we show that, in acute MI situation, it's not mandatory. Rather, people don't go for IVAS in acute MI situation.
I will take these questions, sir. Anything related to leadless, sir will take, and some of them we can answer. What would be the strategy for high-risk complex multivessel with AMI and cardiogenic shock? This is, I don't know which doctor. Basically, that's what is the complete trial, which was analysis was shown. And some even in the cardiogenic shock, actually, it was supposed to be total revascularization was good. That's what we thought. But even one of the trial with shock culprit trial again showed that even multivessel didn't do well, even in shock type of situations. But what is generally commonly we were doing in day-to-day practice were we were treating culprit vessel of acute MI in the same sitting immediately when the patient presents. And probably in a day or two, when the patient is little more hemodynamic stable, before pre-discharge, we were doing the other revascularization of other vessels. That is what hold goods. In the complete trial, stretched that limit to up to on the follow-up about 48 days also it didn't matter. That's why in COVID times, what they're telling is do infarct vessel, and even once the COVID settles, after 2 weeks or 1 month also, if you do the other vessel, still it is okay. I think that's what is the answer for it. And then other role of optical coherence tomography in PCI in future. This is what we were mentioning, as sir was also telling, IVUS and OCT both are good. But OCT, the advantage is you have a lot of clarity, and even the novice can make out the pictures very well. And especially to see the stent opposition and all that, OCT has a better role. But only the negative thing is the contrast requirement. And obviously whichever you have, you can use it. But probably I feel nowadays we started liking OCT more and more. Dr. Sandeep is asking, what would be the strategy for high risk? This is over. And Rajesh, kindly share your process of implementation of post-PCI cardiovascular rehabilitation program. Dr. Rajesh. And would you like to take that, sir? Kahali, sir, or shall I mention? Dr. Vijay, what should be your recommendation for patients with AF and recent PCI? This is another interesting thing. Probably cardiac
So
rehabilitation.
AF and recent, yeah, AF and recent PCI, you know, we have to follow the AAC guidelines or any of the guidelines. Start with the triple therapy. That means anticoagulants. You can go for newer anticoagulants, or if you like to go for warfarin by monitoring the P time, and aspirin for 2 to 3 months, and then clopidogrel. We should not use ticagrelor or prasugrel in this situation for triple therapy. And clopidogrel and anticoagulant we should use from 3 months to 12 months. And after 12 months, we should go only for the anticoagulants. But we should remember that we should keep the patient sufficiently anticoagulate. Means if we give Pradaxa, we have to give 150 milligrams BID. And if we give warfarin, we have to keep adequate P time. So after 1 year, only anticoagulants. And always clopidogrel, no other P2, Y12 inhibitors like ticagrelor or prasugrel.
In other words, to say, probably if you use more antiplatelet, very stronger ones like ticagrelor or prasugrel, along with oral anticoagulation, you could have more bleeding. That's what sir is trying to highlight.
More bleeding, yeah. That's the reason. Yeah, sure,
Then
sure.
Ramdev Yadav posed the question to me, Rota to RCA without TP. I would agree. Probably we did it and we pulled it down. We didn't put it directly in the RCA. We were ready to do it, but probably didn't catch it in the picture. Because some editing of scenes also it happens. When do you prefer IABP in background or off shock tube results? Dr. Archana is asking. Shall I answer? IABP generally, though any trial, if you see it, trial results cannot be made generalized everywhere. As we don't have any other support devices, even in shock type of situations, I would agree, like especially what is the cause for shock you're trying to see. If it is happening secondary to ischemia and arrhythmias, probably putting a balloon will give us some time to revascularize the vessel. And though IABP as such may not be helpful in getting the patients out from the shock, will give us time for helping revascularization. That's how it helps us to cushion the time gap and gives a result on the follow-up. That's why even today, though shock trial with IABP came negative, we take the help of IABP in some patients in shock as a desperate measure. But I would agree, if you have more devices like Impella or LVADs, then which people use aggressively outside. But in India, all those are the difficult choice, especially in shock. Sometimes patient will survive or not. Also, we will not know it if you use all that. Sometimes it's very challenging to bear the cost. As long as the patient survives and go, everything will be fine. If something happens, then who will pay the cost? All those issues will come in the country. I think that's why still IABP is helpful for us in a day-to-day practice. I think we have finished our questions. Anything else, Dr. Hazra sir or Kali, you want to say?
Shock. Let's start from the bottom. This is called DTU trial. Now we don't talk about door to balloon time anymore in 2019. We talk about DTU, door to unloading time. You cannot put even a wire in the coronary without putting in an IBP. So that's the trial says. And preliminary result says that if you have a large anterior wall MI, BP is just standard, you have to put IBP. Now in shock 2 trial, 78% of patients, they had IBP after they developed shock.
Yes.
As Dr. Sreenivas was mentioning, appropriate timing is very important. If you think IBP is required, please take it. Otherwise, go for Impella. And cost is definitely important. About PCI, we have cut the cord with the aspirin. That cutting the cord may be very evident on the very first day or first week. Get married with your NOAC, as Dr. Kali rightly mentioned, dabigatran, with your clopidogrel preferably, but somebody can use ticagrelor because 6% was the case in Augustus, 12% in redual PCI. It's not that ticagrelor was not used, but small in number. The prasugrel was use was 1%.
Yeah, but Dr. Hajira, it is not mentioned in any of the guidelines. They have specifically told in the guidelines that don't use ticagrelor or prasugrel. So we have to follow the guidelines.
Yes.
Even if you go to the European guideline or the American guideline, they don't tell about prasugrel or ticagrelor as the P2Y12 inhibitor of choice.
Only 1% had prasugrel.
Yeah, there may be some incidences in the Augustus trial, but it's not mentioned in the guidelines. So we have to follow the guidelines.
Okay, I use ticagrelor.
Either the European or the Indian or the American guideline, whatever you follow.
I use only ticagrelor and one. Anyway, so Lepman, somebody was asking about the rehab. In 2020 SCC, we have two new informs.
That you can use, but it's not guideline recommended. I don't want to criticize anybody, but what I told is true.
Okay, even in ACS, you can stop one antiplatelet. Kiko 2020, 3,000 patients in South Korea. Say Lepman PCI, if it is ACS, you can stop aspirin even at 3 months.
Basically, probably with better quality stents and with more potent antiplatelets like ticagrelor and prasugrel, people are trying to get away from aspirin because aspirin was increasing the bleedings, and once the bleeding happened, patient was having more mortality. I think we are running out of time.
I lost my connection.
Dr. Sethi is back.
Sethi sir has come. Sir.
Wait, I lost my connection. The internet stopped working, and
Initially, I lost my connection.
Sir, we are able to see you, sir. We are able to hear you, but no picture. Camera should be started on, I think. Your camera.
Don't see the picture?
No, we are able to hear you
okay,
well.
Sir, we can listen to you. Dr. Sethi, sir. We can listen to you, sir.
Yeah, now we can.
Now you are visible.
Yep, sir. Any final comments, sir, before we close? Because of the...
Yes, there are two small little comments that I would like to make.
Please.
The first thing is that you have shown the NIC data of last year, which was a very, very good point to make. That showed that we have increased our imaging from say 1% to 4.2% of the procedures, but still you would notice that 95% of the cases are done without imaging. And also worldwide, not more than 10 or 15% of the cases, including left mains, are done by imaging. So it's not something that is done by every single lab across the globe, but things are getting better.
Absolutely.
That was my purpose of showing a case without the imaging, to reiterate confidence in people that imaging is not end all and be all of everything, and we can still do things without the imaging, provided we select the right cases. The second point that I would like to make is about the syntax score. And certainly today, when you are deciding between surgery and intervention in a complex patient or a multivessel disease, calculation of syntax score is extremely important, and a discussion with the surgeons must be done. Higher the syntax score, more is the inclination towards surgery. And that's a very standard principle one should not forget. And lastly, about the last case that Sreenivas showed, about the patient who had triple vessel disease with subtotal occlusion or almost total occlusion of the LCX. If I was given to do this case, I would certainly go for the LCX first, because God forbid if we fail to do that, then our choice is surgery. As far as the LAD is concerned, whether or not the FFR would have turned positive was anybody's guess. And having done the LCX was doable. I mean, almost 99% it would have been a successful situation. But if I was given the choice, the standard teaching, which I think the rule should not be forgotten, that we should always do the most difficult lesion first.
That's what I mentioned also, sir, in the flow chart, and while presenting also, I
comment to you is that I don't remember the questions that I asked you, but it is very kind of you to still remember some of the things that we discussed during your examination.
No, sir, it is all a lifetime thing for us. And because of you, because of all your teachers, we are like this.
If I'm allowed to make
one more last comment is that your comment that nobody was passing in the last 2 years when I was coming as an examiner is, I think, completely unfounded.
No, not because of you. Before, sir. You didn't.
In my life, I have always respected merit. And you are a meritorious student, I remember that.
Dr. Savitri Srivastava was responsible for not
very well after that, and congratulations to you.
Thank you, sir. Dr. Savitri Srivastava was responsible, not you, sir.
Sreenivas, I want to make a comment, a compliment to Dr. Sethi. I still carry his book on atherosclerosis. And during my PGI days, he helped me a lot. He has many books. He's a great orator. Said, would you treat a heart failure patient, congestive cardiac failure patient in 2020, based on ejection fraction, which is 35, 34 this side, 36 that side?
Yes.
The corollary to your syntax coding, because there are a lot of criticism on syntax coding in 2020, because it is anatomical. We have IFR syntax coding or IVA syntax coding or clinical syntax coding. So these all historical, we have moved with the time, with the technology, with artificial intelligence, machine learning, deep learning, more experience. So some platform is definitely required, but should look back and some have some criticism of the syntax code. That's what I wanted to make.
Yes, you see, the
right that high syntax code needs surgery.
The tools are emerging, but I was only quoting the guidelines that as the syntax score goes high, one has to check patients with ventricular dysfunction with multi-vessel disease. One has to always think that surgery could be a very significantly good option in them, particularly if the anatomy is suitable. But then again, having said all that, there cannot be a rule of thumb in this. One has to individualize and see what can be done best for a given case, including the experience of the center in which the procedure is being contemplated.
My criticism is this recommendation or guideline is not based on RCT. Like metformin, is not based on RCT. That's the only criticism I have.
Yes, 85% of the guideline comments are not based on RCTs. In fact, that analysis has been published that whatever is written as class 1 indication in all guidelines, including revascularization and everything, there is a very good publication about this, that only about 15% of the guidelines are based absolutely the way they are supposed to be based, that is on RCTs.
Thank you, sir. Over.
Sir, I just to continue your discussion on what comment you mentioned, I did mention that we were trying to do LCX first, but because the LED became unstable, we fixed it.
When you become a teacher, you must always make these.
Sir?
Sorry, I said when you become a teacher, there are so many people attending.
I know.
So find out those issues.
Yeah, while telling the lecture also, I highlighted that point.
I know about that, but I wanted to re-highlight the whole thing, that principle is something that most of us should follow.
Yeah. And then the other thing which I was very happy was the multivessel, how FFR behaved after the area of supply of the vessel is important to...
That was a very interesting observation.
That's why I wanted to highlight that.
Right coronary artery and your FFR.
Yeah, very nicely shown, Sreenivas. Yeah.
Right, sir. Thank you, sir. Thanks, sir. It's always a pleasure again interacting with all of you. But we have to close, I think. Any final comments from Lupin? Indrajit?
Yeah. Thank you, Dr. Kali, Dr. Hajra, and Dr. Sethi, as well as Dr. Sreenivas, for having such a wonderful lecture for the same. And I think most of our audience have enjoyed the discussion and learned out of it. I really apologize for the technical issues that has happened in between, but however, it was a great session, I believe. Thank you very much for attending the session.
Okay, thank you, Indrajit. Thank you, Lupin. Thank you very much.
Thank you, sir.
Thank you all.
Thank you.
Thank you.
And bye-bye.
Thank you, Sreenivas, Professor Sethi, and Hajra. Thank you.